seminar. I'm delighted to welcome everyone here. I'd like to pay my respects to the traditional owners and the lands where we're meeting, and elders past, present and emerging. Farshad is well known to all of us, an academic radiation oncologist at Ballarat and at the Austin, and he is going to tell us about the State MR Linear Accelerator service. As always, please post your questions as we go. Thank you, Farshad.
Thank you, Bruce, and thank you for the opportunity and the invitation to present today. I'm just going to share my slides. So if let's see if I can confirm. Can someone confirm that they can see my slides?
Yes, we can. Perfect.
Excellent. Thanks. So thanks again, Bruce and Belinda, for the invitation. And I'm going to present today on the State MR Linear Accelerator and our MR and program and opportunities for breast cancer management. So first, I'll go through a little bit about a background, opportunities, some of the challenges, some of the clinical trials we've already opened in terms of volunteer imaging, looking at a single fraction pre-op treatment for early breast cancer, and a simulator-based MR contouring study using Barrigel, and also highlighting that there's a lot of other opportunities. So the background, our journey actually goes back now close to 3 years, where the funding announcement was by the Premier Health Minister. Both the Linac and simulator are both first in Victoria and third in Australia. The Linac is planned to go live next month, so quite shortly. And the simulator, which we funded from Austin Health capital funds, is already clinical and being used. So just to go back in terms of a background, this is a conventional linear accelerator, and we have a number based at our O&J site, as well as similar machines from a different manufacturer at Ballarat. And there's throughout Victoria and Australia, this is what's generally conventionally. It has what we call a KV source and cone beam CT, and kilovoltage images can be taken. This provides soft tissue information and bone imaging. The bone imaging is quite good, but the soft tissue imaging is generally worse than conventional CT. This is what we purchased, is a Philips Elekta Unity MR Linear Accelerator, and this is what's being installed, has been installed in our department. If you look at the cutaway, you can see that there's an MR scanner in the middle of a donut, which is actually the gantry, which is a solid 3.6 meter circumference, which the linear accelerator rotates around. And while this looks elegant, it has actually been 2 decades worth of work to get this developed and commercialized, with most of the initial work occurring as an academic commercial collaboration led from Utrecht in the Netherlands. And I believe now there's over 100 orders of this commercial system, and similar for a different system made by American company called ViewRay, which uses a slightly lower end, a 0.35 T magnet. And the system, I'll show you what it finally looks like. So this is what the MR simulator looks like. We also purchased the ambient experience, which is allows for videos to be projected on the wall, and also patients to be able to see video during treatment. I suppose it's to make it a more user-friendly experience, and I suppose staff can also watch pleasant videos too, but it is aimed at patients. And this is the Philips Elekta Unity with all the covers on. So it looks quite different to the cutout, but you can see there's where the patient goes in, the couch, and there's the MR, and then the linear accelerator which rotates around it. And to just highlight what the sort of potential benefits are, I'm just going to go back a little bit in terms of what radiotherapy over the last few decades. So the photo on the left is a historical image of the first patient treated with a linear accelerator, and that was in Stanford, a 2-year-old boy with a retinoblastoma. And this is a very famous photo, and I believe he's still alive. And as you can see, the patient, the boy's just been put on the couch, and the large linear accelerator has just been aimed at his skull and where it's thought to be the tumor. Then moved from that to being skin markings, and this is showing bilateral breast cancer, and you can see there's skin markings which were used from the 50s to 80s and even some places the 90s. So radiation oncologists had to become quite good at surface marking and surface anatomy. In the last 2 decades, from the 1990s onwards, megavoltage imaging, which provided some soft tissue and bone information, but poorer than X-ray quality, was available. And since the 2000s, kilovoltage imaging, which provides quite good bone imaging, but certainly not sufficient to see soft tissue. But cone beam CT can be done, which does provide some soft tissue imaging, as I said, but not quite as good as the resolution shown with CT. I have to apologize, this isn't a breast, obviously, but this is just showing what cone beam CT compares to MR. So with an online cone beam, seeing the node compared to some of the surrounding vessels and structures, really there's a dramatic difference with MR. So then I'm now going to talk a little bit about the opportunities for MR linear accelerator use, and then a bit of the challenges in breast, and then some study. So MR in radiotherapy, MR does provide superior soft tissue contrast. There's better visualization of the tumor and organs at risk, certainly compared to megavoltage or kilovoltage imaging. There's a possibility of margin reduction, reducing the normal tissue irradiation, which can potentially reduce side effects of treatment. And this applies not just in breast, but in primary, but in a whole lot of other indications for breast and other tumors. There's the ability to do response assessment either during or even after radiation treatment, and possibly discovering early recurrences, which I know there's been quite a bit of work on in the past. So possibilities of MR in RT can include low risk breast cancer, treatment de-escalation, so with the better imaging and localization doing partial breast rather than whole breast irradiation. There are some preliminary studies suggesting local control and survival are similar, but very short follow-up for this group of patient. And toxicity, certainly on the MR studies, are quite favorable, but again, small numbers with sort of fairly short follow-up, which I'll go through. Nodal irradiation, because it's actually possible to visualize nodes on MR, and oligomets. This is just showing the difference between MR and CT. On MR, the sort of clips or any fiducials are a lot more difficult to see, and they're generally seen as voids, in contrast to CT. But certainly, the tumor generally is far easier to delineate on MR than CT. And as most of you know, on MR, fat is your friend, as your friendly radiologist will say. So it's actually quite a contrast to most other medical conditions or what society expects, but certainly fat does help to delineate and show tissue planes. Again, this is just hypothesis, but from Utrecht, where the MR Linac was created, looking at nodes and whether sort of tailoring to nodes is feasible, and then whether or not that may potentially sort of reduce toxicity, but obviously trying to make sure that control remains sufficient. Again, lymph nodes, a whole variety of nodes may be easier to see on MR than some of our current modalities of imaging. In terms of the difference between radiotherapy imaging and what our colleagues in radiology do, so we really try and optimize in terms of spatial or geometrical integrity. Really, in terms of the signal to noise ratio or tissue contrast generally is not as important to us as making sure that it's geometrically correct. So really 1 to 2 millimeters of spatial variation can cause upset to your friendly radiation oncology team. This is showing conventional radiotherapy workflow, which many of you may be aware involves imaging, contouring by radiation oncologists, radiation therapists, prescription planning, which can either be 3D conformal or more commonly now modulated treatment, evaluation of a plan, and delivering radiation treatment. This obviously is a head and neck example, but similar principles apply for most body parts. Well, with the MR Linac, there is the ability to do imaging on a daily basis, re-optimization, and you can re-optimize to either position or actually to the shape of the organ or tumor on a daily basis. For breast, most commonly it has been done to adapt to position rather than shape. So again, the idea of adapt to position or adapt to shape. I might now go through, there are some challenges with MR in breast radiotherapy. One thing is the timing. In terms of doing preoperative radiotherapy, there are a number of benefits compared to doing standard adjuvant postoperative treatment. One, the inter-observer variation or ability to detect the primary is generally better on a preoperative than a postoperative setting, and the volume is generally significantly less. And the benefit of tighter radiotherapy margins, reduction of a margin of even about 5 millimeters can result in a decrease in volume of up to 50%. And this isn't any fancy radiotherapy knowledge, it's basic high school geometry. It's a sphere, and if you reduce by 5 millimeters, it actually is quite a significant volume, and shown in this image with an an orange. So again, preoperative, you also have the other benefits of tumor response, both with imaging and pathological comparison, potentially a better cosmetic outcome because the high dose radiotherapy volume is excised. And with MR planning, surgical clips do lead to voids, so potentially could be less accurate target volume delineation. So, and I mentioned there is some early results, both with the ViewRay system, which initially used cobalt, but now using a linear accelerator, single fraction adjuvant partial breast, at very short follow-up, low toxicity, good cosmesis, and no recurrences. And again, the MR Linac, low toxicity, but far too early results to comment beyond that. This just highlights some of the artifacts and how markers can have an impact on MR. There are ways around it, but the advantage of sort of localizing the tumor rather than the marker. There are difficulties with MR, particularly this is an example of a CT commonly used in radiotherapy is 80 to 90 centimeters in diameter, while most MRs, and including the MR Sim and MR Linac, are 60 to 70 centimeters in diameter. so that by the time you fit in a patient, you fit in potentially a breastboard, a receiver coil, there isn't very much room. And positioning, whether supine or prone, can get very tight for patients. It is possible to image without a receiver coil, but then the image quality does decrease if you don't have that in place. And if you do compress the breast, that obviously affects your anatomy and dosimetry. So as I say, this is a breastboard we examined, and really it was sort of, with the shape of the board, we were sort of very much limited to thinner patients, which limits the ability. So we're getting a custom board created, which has got some varying heights. And then prone versus supine in terms of position. There's pros and cons with both, and it depends on the tumor position and patient size, and those things need to be worked out in individual departments, so that you can fit the patient, the immobilization and the receiver coils. Another challenge, which is also able to be overcome, is the electron stream effect. So normally with a linear accelerator, you do get dose that can spread beyond the radial area, but that is normally random. But with a magnetic field, the electrons spiral along the magnetic field, so they would be going along the axis in the MR. So theoretically, and it's actually been seen initially in some of the patients, there was dose deposited in the chin. It is possible to get around that fairly easily using like a bolus material, so there's minimal dose going to the chin. Another issue which I already alluded to is geometric accuracy, which is something we're very keen on. The linear accelerator, the sort of isocenter is well under a millimeter. However, the MR can have distortions, which can be up to 2 millimeters the further you get away from the central axis. And ideally, you want the tumor and the target to be close to the central axis, but breasts are generally a lateral structure, and it really depends on the patient's habitus as well as the tumor position, but it could vary from being 10 to 20 centimeters from the axis. And again, these things do need to be taken into account. Another technical thing which our planning system can take into account is the electron return effect. So this is minimized by doing partial breast irradiation rather than whole breast irradiation, and also by using multiple beam angles rather than a sort of 2 or 3, and as I say, can be modeled. Finally, we do need to be careful with some of the angles used because of features on the MR Linear Accelerator, including the rails at the side as well as the cryostat pipe. But these can be done and entered in a planning system, and you can do adapt to shape, adapt to position, and a full online plan adaptation. So they've been worked through. Movement can be taken into account, breathing, as well as irregular movement and bulk movement. This just shows the example of some different motion and how you can take into account generally breathing. Then there's some of the standard issues with MR, including MR safety. For our department, we've had all staff do basic safety training. We also have all our clinical staff involved doing level 2 training. We have a magnetic safety officer and also a medical lead. And if you look on the classic photos, it's generally the cleaner or porter, and us MR staff and MR radiographers are actually going to take that responsibility to clean the room. Now I'm going to go through a bit about clinical trials and clinical research. So there's no level 1 evidence for MR linear accelerator. So MR plus a linear accelerator does not equal level 1 evidence, but this is actually a great opportunity for collaboration, development of local protocols and collaborative research with our colleagues, both locally and interstate and internationally. We've got a number of studies. The first one is very much been to optimize our imaging and what we've called a volunteer study. We've been through staff volunteers, and now we've got a series of patient volunteers. So to try and get our image quality and sequences determined, and also positioning and reproducibility. And what we've been looking for is patients with basically pre-op, early breast cancer, clinically node negative at Austin, and looking also at things like prone versus supine, the breast board. Okay, and the accrual for that is 5 patients. We've waiting on a new breast board, but we should finish that fairly soon. Next, there's a NBCF funded study called RICE, which is magnetic resonance image guided single fraction preoperative radiotherapy for early breast cancer. The primary objective is to see feasibility of a single fraction of neoadjuvant radiotherapy. Secondary objectives, comparing MR imaging to CT cone beam, and also there's a novel FES PET and FDG PET component, and comparing that and also pathological response. So HREC approved, and we're hoping to start fairly soon. Just the background, it's a single fraction compared to what we conventionally do of often 3 weeks of hyperfractionated treatment. Talked about it, sort of accelerated breast, target studies, and also Elliott. Certainly MR offers better ability to localize breast tissue and the tumor compared to cone beam CT. So this is very much a feasibility study. Patients that have MR, planning CT, FDG and FES PET, MR radiotherapy planning, the single fraction 21 gray, MR to assess response, and then surgery 6 weeks after radiotherapy with pathological review to also assess response compared to imaging. The first stage is the Sim, and second with the Unity, and both of them are matched in terms of 1.5T MR. Inclusion, older patient age group over 60, unifocal, tumor less than 2 centimeters, grade 1 or 2, ER positive, node negative. So very much a low risk group of patients. Exclusion, previous radiotherapy, lobular, any evidence of nodal disease, so contraindications to MR or PET CT. Sample size is planned to be 30, and we hope to recruit over about a 12 to 18 month and a 5-year. We've been funded for 5 years. And finally, this is a brief study being run by a couple of our colleagues, Michael Chow, Janice Ye, and Sue Wen Low, breast surgeons. So it's looking at Barrigel, a tissue fiducial marker compared to surgical clips for post lumpectomy cavity delineation. It's actually open, HREC approved. We got an Austin Health grant for it, and recruitment's underway. The idea is to, again, in a sort of smaller tumors, less than 3 centimeters, looking at Barrigel, both on CT and MR, and also surgical clips, and doing 6 observers and trying to find that inter-observer variability to see the effect of MR and Barrigel. They won't be used, so it's a inter-observer study. They won't be used at this stage for clinical planning of the radiotherapy. So just a couple of final slides about the MR Linac service. The plan is the clinical indications where there'll be maximum benefit from MR guidance. And as I've shown, the breast at the moment are very much studies and research and development. Patients would be referred in for the radiotherapy component and then go back to the originating service, and we try to minimize patient-led referrals. In terms of our funding, we have to acknowledge Department of Health provided the capital for it. We also got some funding from our Hospital Capital Specific Purpose Fund. Operational funds come from Department of Health. But what we're very keen on is research funding. So we so far got some NBCF funding, Austin Health Medical Research Fund, and also some from our departmental research fund. So in conclusion, MR guided radiotherapy, we've got our first MR Sim and MR Linac technologies, but I expect over time this will become more common in Australia and Victoria. We've got a patient volunteer study, which is being completed. Ideally, we want pre-op patients for that. RICE, which is a single fraction study for low-risk patients, a contouring study. We're very keen for collaboration and opening future studies and trying to develop some of the evidence. Just to indicate, even with these limited studies, it's a big team. We've got breast surgeons, radiation oncologists, medical physicists, and not just from Austin, but from beyond in the VCCC, and linking also with imaging and also the multidisciplinary team. So I'd just like to thank everyone for the opportunity to present, and happy to take any questions or also be contacted at any time. Thank you. Thanks, Bruce.
Thanks, Farshad. That's very interesting. I'm sure there will be some questions. I'll start. In the overall, not just breast, but in radiation oncology in general, where do you see the most value in the extra precision that you've demonstrated can be offered by an MR Linac?
Okay. So, in fact, what we did and DHS supported was across all the public departments, we had representation to look at indications, and we created a list of 17 indications. And they were predominantly areas where the current imaging limits the ability to either deliver radiotherapy or you get suboptimal doses. So things such as oligometastases close to bowel or some of the organs at risk, pancreatic cancers where there's surrounding small bowel that again limits radiotherapy, some of the reirradiation where you're trying to do very small volumes, so head and neck reirradiation, prostate reirradiation, potentially even, and I know Michael has talked about a breast, so early breast cancer, if you were possibly going to do a reirradiation study for that to see about wide local excision again. So it is very much in selected indications at present.
Yeah, I like the last one you mentioned, because we're doing some work using contrast imaging in surveillance. Now we're using contrast mammo, but it's fairly similar to MR in the findings, and are finding some very early and very small areas of local recurrence. And we do have a bit of a dilemma because following standard guidelines, these patients should be advised to have a mastectomy, but it does feel like we're often over-treating.
Yes.
Is there any, what's the experience of re-irradiating, say, a central part of the breast in a type of partial breast radiation? Is that likely to be successful or problematic?
Again, it really depends on the volume. So if you can have a small volume, the toxicity should be less. But this is, again, would be very much done as part of an ethics approved study to try and collect data and determine. But I think every radiation oncologist would be reluctant to do large volume or whole breast. But if you can have a small partial breast or able to localize, and it may be quite reasonably tolerated. Okay.
So any questions, please put them on the Q&A, and Another one from me with the RICE study, with the pre-op, the pathological assessment of response. So the idea is essentially pre-op / neoadjuvant radiation, single fraction, MR for response, then 6 weeks later surgery. How is that going to be assessed? What's the pathological endpoint?
So we've got two pathologists, two of our anatomical pathologists who are investigators, and they were going to obviously go through and try and see if there's any viable tumor and use some of the standard pathological criteria, and hopefully be able to try and correlate the location to some of the imaging, but that's still very exploratory, would be very exploratory for us. So
most of the primary endpoint is really feasibility.
Yes, that we can technically deliver the radiotherapy. This would be the first study, and if we can show feasibility and get some of those other pilot, then hopefully we could do a larger scale study with collaborators from either interstate or if there's another MR Linear Accelerator by that time in Victoria, so that we could have a phase 2 study following.
I guess the other possibility, if this could be, as everyone knows, I'm not a radiation oncologist, but the single dose, how does that compare to the dose that would be delivered in stereotactic ablative radiotherapy?
It is lower, and we're not doing a stereotactic treatment. It's like an adjuvant style dose. So there is some literature showing that at a longer time period, about half the tumors didn't show any viable tissue, but we're not trying to do ablation. We consider this as an adjuvant treatment for this group of patients.
Does the machine that you've got, could it do ablation, or
yes.
does it need to be some different engineering?
No, it's just a dose that is chosen, the dose and fractionation, and also the way we prescribe. With ablation, we'd often be looking at 130% in the middle of the target or so. But given these patients are having surgery to remove any of if there's viable tumor, we're not trying to get to that sort of 130% because the idea is to use this as an adjuvant to treat the microbe.
Yeah, it could be aimed to get rid of this. Another way of getting rid of the surgeons could be very accurate. I've got a comment from Michael here that he's not trying to supplant the surgeons. I think he should. Okay, any comments from any of the radiation oncologists? This is really quite new technology, and it's good to see it being investigated.
Just Bruce, just to echo Michael, we're very much into collaboration, and this RICE is adjuvant treatment, not ablative treatment.
Yeah. So when we spoke about it early, again, another of the things that we are finding with some of our imaging is small foci of occult lesions. And currently we are excising them all. It does feel that there's probably a threshold below which ablation with radiation would be sufficient. Well, may be sufficient. Yeah. Without data, it's all just supposition. Okay, what are the next? So in the overall program with the MR Linac, what are the, where is it likely to be used most in the next 6 months?
So we're prioritizing studies. But in terms of tumor sites, we've got a sequence where we're starting with CNS and head and neck. Breast is the next one after that. And then we'd be going through some of the pelvic sites. In terms of indications and such, as I said, we're very keen to develop some of the evidence. There's very little beyond sort of short-term studies. So it's a great opportunity to build collaboration and research.
And for the other, in the audience, there are people from multiple sites. The patients who, which patients should we consider referring for consideration?
Well,
are there any at this stage, or in breast at least, are the first ones likely to come from within the Austin?
I certainly think the pre-op and the Barrigel back patients would all predominantly be Austin. Barrigel could be some patients who also have surgery elsewhere, as long as the surgeon and the team are sort of willing to be involved with Barrigel. And in terms of RICE, if a patient and a clinician wanted to look at the single fraction pre-op, we would be willing to have that referred to us, and then the surgery, we'd want the pathology to be at least reviewed by our pathologist after.
So it would be difficult.
Yes.
It's probably more for the subsequent phase after
Yes.
your initial few.
Yes.
All right. This is all very interesting. Do we have any questions from the audience? I can see who you are. You must have some questions. I'm sure when people do have a think, they will get in touch with you, Farshad. I think with that, we might finish up. Thank you for your attendance. Thank you particularly, Farshad, for giving the talk. It is great work. Looking forward to it. Sorry for the technical issues early on. In 2 weeks, we have another speaker from the Austin, Alex Murphy. Looking forward to that, and thank you all very much.
Thank you, Bruce, and thank you.
Thank you.